I mean, doing just the soft tissue work may not help the patient at all. So then you have an idea that yes, there will have to be some work to be done on the hard palate, which is the only way that the collapse is going to improve. So before you go in for any kind of soft tissue work with dyes is very important, and you should decide what type of phenotype it is and then go ahead with the soft tissue.
Right, so for the information of the audience and the residents particularly, usually we categorize palate into 3 phenotypes: oblique, intermediate and vertical. And this last variant, these vertical palates, where the soft palate is almost like hanging like a curtain from the back end of the hard palate, are something to be taken very cautiously, because here the block is usually at the level of the genu, and whatever the soft tissue procedure we do at the level of the palate, the soft palate, there is a chance of failure because we have not addressed the genu, because the hard palate is long in these cases. So many times for these kind of patients, palatal, transpalatal advancement is recommended rather than going just straight away jumping upon the soft palate doing any procedure. Dr. Srinivas Kishore, your opinion, your comment on this?
See, I think it's what is very important that we need to understand is that when we look at the phenotype and we are looking at endoluminally, yes, this is very important. But how do you pick it up easily is 2 things. Once, which is a very, very important thing that when you start assessing your patient in an outpatient is your skeletal profile, right? You need to know if the patient is class 1, class 2, class 3, because if the patient has retrusive maxillae, it is very highly probable that the patient might also have a vertical palate.
Right.
So a simple lateral X-ray cephallogram can give us a lot of information about this.
Yes, so before taking any decision of any kind of palatal surgery, it is extremely important to understand the phenotype of the palate. So, assessment of severity of the disease. Again, I start with Dr. Srinivas. What is your opinion? In your opinion, what is its importance, assessment of the severity of the disease in context to surgical outcome?
See, I think the severity of the disease, whatever you're speaking about, is the understanding the physiology of the disease, the pathophysiology of the disease, or the impact that this particular condition is having on that particular individual. Right? So this is very, very important because we need to know the disease impact. So it tells us 2 things. One, it tells us the need for treatment, it tells us the urgency for treatment, and it is also telling us the impact that it is having on the particular individual in terms of heart rate or neurological status or arousals or whatever. It actually tells us gives us an understanding of the entire night's sleep if you really look at the data.
Right. Shaktish, what do you do? Level 1 or level 3? That is home sleep test or level 1 in lab test?
I do a home sleep test. I do a watch pad, in fact, which is classified as a level 2 study.
Right. Raju?
So normally home sleep test only.
Normally home sleep test.
Yeah. Suppose you suspect anything suffering more than sleep paralysis or restless syndrome, then you like it's level 1. It's level 3.
Dr. Vijay, what are the cardinal parameters to look for? Your message to the audience and particularly the residents, when we look at a sleep study report, what are the 3 or 4 most important parameters we should look first?
So that depends upon whether you are doing a level 1 sleep study or a level 3, type 3.
Right.
So the sleep efficiency will tell you how much the patient had sleep disturbance, and that will be picked up only with level 1
Right.
or level 2. And sleep architecture is also very important. And the AHI or DA is the value which will can be easily explained to the patient how severe it is for the patient to explain. But that also tells us how many apneas and hypopneas are happening. But that alone is not sufficient, as we all know now. Because the duration of apnea and hypopnea is also very important, and if the apnea and hypopnea, the numbers are different, then the AHI can be same. So that also very important to understand what is apnea index and what is hypopnea index separately.
Right.
And the most important, as we were discussing about the severity of the disease, that is how the disease is impacting for totally depends upon the oxygen desaturation index. Because ultimately, whether it is apnea or hypopnea, the desaturation which is happening is the major cause for all the systemic disturbance. So the ODA is one important factor which will tell the disease burden to the patient. So the ODA also has to be further classified how much is the desaturation happening at what level, whether it is below 70, below 60, or even sometimes patient may have below 50. So that also has to be deeply looked at to assess the severity of the disease or the and also we have to look at the comorbid conditions, whether the patient is already having a diabetes or hypertension or cardiac issues.
Right.
So when the patient is already having some cardiac issue and even AHA of 10 may be very significant for them. So just you can't say AHA 10 is mild or moderate disease or something.
Right.
So other comorbid factors also to be looked at.
Right. So, Dr. Ranjit, to conclude this particular slide, I would like to listen to your opinion and message to the audience. What is in your opinion? Suppose if we do level 3, not level 1, does it impact upon the surgical outcome? That is, level of sleep study, is it a compromise or is it a practical? Suppose if we do level 3 study, we cannot measure sleep efficiency, right? Is there any role in surgical outcome ultimately? So what is your opinion?
No, it's not that.
To make it simple, level of the sleep study
Level
has
three
any
should
role
be-
upon the ultimate surgical outcome.
Level 3 is also something which can be done before doing a surgical outcome. I don't think that affects it much unless we are suspecting other conditions like narcolepsy or things like that, which can also cause an additional sleepiness. So post-operative, the patient may still say that he is sleepy. For such conditions, of course, a level 1 or level 2 is important. Because otherwise, I think a level 3 sleep study should be fine for even before you go for surgery.
That means to select the proper surgical candidates. That means during the history and the evaluation part, if we see, yes, actually this patient is not actually a garden variety of sleep apnea at all, and jump upon surgery in these patients, definitely the outcome will be compromised.
Yes.
And that is not fault of the sleep study. It is actually
Your history is
exactly. Punas lies on us. We didn't evaluate it properly. Right. Now regarding surgical planning, the most important statement is selection of the correct procedure to be performed on the correct patient. That actually all defines the success. Then again I start with Dr. Ranjit. What is in your opinion the global versus local philosophy, its importance in surgical outcome? Global versus local. Yes, please.
Definitely, sleep apnea is a global, it is a holistic approach of treatment that we need for such a patient. So, when I look at the BMI, I always tell them about reduction in BMI. So that is very, very important because when the BMI is about 32, until about 32, I advise the patient that we can go in. But once it's about 35, I generally advise the patient to go in for a bariatric surgery. Even if he has a huge tonsil and heavy sharp DNS, just correcting that may not improve the sleep apnea and his snoring. So that is one thing that I always tell the patient.
Vijay, in your opinion, weight, that is the system, any kind of systemic pathology or this body mass index, whether these are any candidacy criteria for surgery or not?
For a palatal surgery,
Means my question very simple, whether we cannot be operate upon obese patients.
So usually I won't do surgery for BMI more than 30.
Yes.
Unless they have an intention to reduce weight further.
Right.
Sometimes if it is in a crop of 32, 33 and if they are willing to do regular exercise, I may ask them to start it first before doing the surgery.
I want
Yes,
yeah.
sir.
So this stop and posture actually itself actually we are dealing with the BMI and next section. Everything is there in stop posture. But I have a patient, I had a patient actually, it's 147 kg. So BMI is more than 40, but he had only soft pharyngeal foot collapse actually, no collapse at all. So this AHA is only 40, that's all. Okay. Actually, we did a sleep endoscopy. This patient has only soft pharyngeal foot collapse and my tonsil. So remove the tonsil as well as we did channeling and reduction of soft pharyngeal foot. He's doing better now. So maybe the weight BMI is maybe high. So do a proper rapid sleep endoscopy and find out what's the exact level of obstruction and do proper surgery. Definitely they will do better. But I agree with the Ranjan, definitely we have to advise the patient to do exercise and reduce the weight to improve the total outcome.
Suppose if we have this kind of oropharyngeal finding in a patient like left-handed picture, Dr. Srinivas, your opinion, cannot be operated?
So that's the thing, right? See, in obstructive sleep apnea, the problems are in the airway are combinations of collapses and obstructions, right? And if I see in a patient whose BMI is about 35 and who's got static obstructions like grade 4 tonsils, grade 4 adenoids, grade 4 lingual tonsils, there is no point to even leave him for a CPAP because CPAP cannot work. So it's like stage 4 cancer. You combine treatment, you make the disease burden less by removing all the static obstructions and then put him on CPAP and then maybe manage his fat.
Yeah, that's this container content conflict. So, your take, how to look at it? This container and content.
See, basically,
We should treat container or content.
so if there is, so there are again, that's why understanding the phenotypes are so important. Even if the patient is obese and the container is normal and the contents are too many, and those contents are obstructions, not collapses. And that is why what Anand has said is very important, because once you do a drug-induced sleep endoscopy, you can actually differentiate between your obstructions and your collapses.
Not collapse, yeah.
Collapse is very difficult to treat. Obstruction is a low-lying fruit.
Yeah.
We will pick it up.
Yeah. Great. So, guys, drug-induced sleep endoscopy. I will start with you. A role of drug-induced sleep endoscopy in surgical outcome, in your opinion, 1 or 2 lines.
I think this is a game changer for all of us. If I have to put it in one word, in fact, I would actually go one step ahead and say drug-induced sleep endoscopy can be a gold standard in the surgical evaluation of our sleep apnea patients. Because it can not only give us insights into what could be the probable causes and the behavior of the upper airway, it is also going to pick up certain small things like, like epiglottic collapses, like tongue-based collapse. These things can be picked up more on drug-induced sleep endoscopy. So, and also treatment failures. You have done a wonderful procedure that there is a treatment failure. You want to evaluate your treatment failure. For surgery, I think this is one step short of being called gold standard.
Ranjini, your opinion. Your comment.
Definitely, DICE is the procedure which has to be done before we think of any kind of surgical procedure. Because I don't think there's any other way that we can even find out an epiglottic collapse. So, and sometimes...
Don't say that. Me and Vijay had some discussions on that.
I am talking about mine. So, I think DICE is mandatory before we think of any kind of surgical procedure.
Vijay, your opinion.
So both DICE and dynamic MRI are complementary, and as we're discussing that palatal phenotype, which can be easily picked up in a dynamic MRI than DICE, where we get a sagittal view, axial view, everything. So that one thing is a nice example, and also we will also be able to assess the parapharyngeal soft tissue and how much is the fat content in the tongue. There are so many parameters which can be assessed simply with dynamic MRI.
Dynamic obstruction And among these dynamic obstruction, we look at the soft tissue, skeletal and combined. So, my question, one sentence actually from each of the esteemed panelists. This is almost our last part, one slide. Take home message from you. Recommended approach, any difference from this flowchart? Start with Ranjini.
I agree with you, Deepanka. I don't have anything else to add.
So we have a gamut of options. All this syllabus in this slide, starting from the healthy lifestyle, is the fulcrum of OSA management. Then we cannot ignore the allergic rhinitis management. In fact, the previous panel, we know how far it is important, and we deal with plenty of allergy patients in our clinical practice, ENT chamber. Then the conservative approach like CPAP, needless to say about these oral appliances. Then comes the role of otomyofunctional therapy, be it analog or gadget dependent, no debate about that. Hypoglycemia pacemaker, that is neurostimulation. It has its role in select few patients. They are doing, but it is not a panacea because they are getting their failure also. And needless to say, if the patient is failure to any conservative approach for 2 to 3 months or outright, we detect yes, there are fixed surgically correctable upper airway obstruction. There is role of surgery. So this is in a nutshell the take-home message. Overall, we need to approach a OSA patient holistically. And last but not the least, do not operate. Please don't operate a patient with an unrealistic expectation. So, final comment from each of you. This is the last slide. Final comment. Vijay? As regarding this,
Yeah,
a patient with unrealistic expectation.
Not only with surgery, any surgery,
Yes.
patient with unrealistic expectation not be touched. So, as we have to see the patient as a whole, OSAS history, as we all know, it is a systemic disorder. So we have to treat the patient, not just the airway. And a lot of patients will be having multi-level obstruction that we have to keep in mind. And we have to make sure to correct the obstruction with less complications, and we have to properly counsel the patient regarding the condition of the disease and what is the consequence if we don't treat, and we have to explain the various options like CPAP and surgery and lifestyle modification. The exercise plays a major role, especially when they have a very poor lifestyle, and even after surgery to maintain the weight and role of myofunction therapy has to be emphasized in patients with possibility of more of dynamic collapse.
Excellent. Wonderfully pointed out. Maintenance of weight even after surgery. That is also a very important point to get an optimum and proper surgical outcome. Ranjini, your final comment?
One more point, more the static obstruction, we'll be happy to operate, and
Exactly.
more the dynamic collapse.
Better the result. Better the result. Ranjini, your final comment?
Yes, definitely, because a patient with unrealistic expectations, something that's going to cause a lot of problem for you. That's why I always take the weight in front of the patient, because invariably the weight is much more than what the patient says his or her weight was. So that's very important. That's something I drive home to the patient and the spouse.
Right.
Because the awareness of the spouse is also very important.
Absolutely. Raju?
Yeah, so good slide actually. So I actually we know. So counsel the patient preoperatively, very thoroughly actually. So what is their clear expectation actually, and we have to give a clear advice post-operative also. I agree with Vijay, post-operative lifestyle modification. The only thing is actually I'm giving a lot of myofunction therapy. So for all post-operative patients actually. So as I do a myofunction therapy for at least 2 months. In some patients, immediately post-operative, I will advise use a CPAP for at least 2 weeks to 1 month to improve reduce the edema, improve the outcome of results actually. So the preoperative counseling is very important, as well as counsel the partner also. That is very important to improve the outcome.
So, Santosh, your final comment?
OSA is one condition where the patient should be actively involved in the decision making. So definitely our role should be more of a passive person who is kind of keeping things all the options on the table, and we should actively involve the patient in the decision making so that he understands. And also it is very important to stress upon the it's not a one-time thing. The patient should be motivated to kind of change his lifestyle and follow it, because so we are looking at a long-term outcome. So that is what we are concerned. So the patient should be an active partner in the decision making when it comes to the treatment.
Srinivas,
So,
your final comment.
OSA is a progressive disease. We need to understand that. So, a lot of hand-holding has to be done throughout the journey for this particular patient. There are a lot of analogies between OSA and cancer. So there is no single modality that will work for the patient at all times. So as Sakti said, we should put all the options, and you also will have to sort of nudge the patient in the direction that is best suited for the patient. And that is where evaluation comes in, and so that you can design and custom design the treatment for that particular patient. And of course, last but not the least, unrealistic expectations, of course, but a lot of it also comes from us.
Yeah, exactly.
We should, how we put it across to the patient
Yes.
also sort of matters.
Yeah. So thank you, Chairperson sirs. We have finished. 10 seconds left. Thank you.
Great. Thanks for this esteemed panel for highlighting the various parameters we consider for the surgical outcomes for the OSAS patients. Previously, we used to tell for OSA, it is an extended concept. Give the surgery to the first year postgraduate, that is done. No. Again, thanks for this panel to highlighting that various parameters are there to be considered for this OSAS surgery. Thank you once again for all the esteemed panel.
Thank you very much.
Thank you, audience, for bearing with us.